What I'd like to do is share with you a PowerPoint presentation I put together a number of years ago, really trying to shift the focus from sugar to insulin. Well, without any further ado, let me jump into that. I really observed this as a clinician and observed issues regarding diabetes and coronary artery disease. Comparing type 1 and type 2 diabetes in particular, they are clearly different disease processes. Type 2s carrying extra weight, type 1s loss of weight, type 2s cardiovascular disease. We're really talking about macro versus micro vascular changes. And the challenge, of course, is if sugar is the driver for that disease, that diabetes, then how come sugar is acting so differently in those two states? So if they are fundamentally different, what's driving that? And I put there that it's probably related to insulin levels. And I think everyone agrees on that. These days, type 1s have inadequate insulin, type 2s, excess insulin, and that's what ties in with the cardiometabolic syndrome. We know, of course, that type 2 diabetics with very tight sugar control don't necessarily live longer. So we know that there's not good data to suggest that management of type 2 diabetics is all about being glucose-centric. Well, here are two patients of mine who were good enough to give permission for me to include them in this presentation. One of them is diabetic, one of them is not. And I think the point there is obvious. This guy happens to be the diabetic, and we know immediately he's not type 1 diabetic. We know he's type 2 diabetic because of his presentation, his morphology. This patient is not diabetic, but looking at him, you can't help but think he's on his way to diabetes or will be diabetic. And the reason I'm showing both of them is that they both have macrovascular disease. They both share a common disease process, which drives central adiposity, drives coronary artery disease, ties in with elevated blood pressure, lipid profile, increased waist to hip ratio, so forth. So we know that type 1s with absence of insulin lose weight. We are aware that too much insulin contributes to the metabolic syndrome. So why aren't we putting more influence and more focus on insulin? And just by way of background, if you think about the role of insulin, we've often thought of it from a glucose-centric perspective as managing sugar. Of course, from our evolutionary past, insulin was never set up to manage sugar. It happens to do that, but it was really set up to take advantage of seasonal good times so that our hunter-gatherer ancestors, if they did have an energy-rich opportunity for food consumption, that insulin would capitalize on those feast times. The problem is these days, we've got pantries and refrigerators. So if insulin really is the problem, then how do we understand that a bit better? Because we do see people who can sort of get away with eating what they like. And we see people who put on weight readily. And we also see people who are somewhere in between. Now, this isn't a new description. This has been described as ectomorphs, endomorphs, and mesomorphs way before my time. But could these different sort of responses to the way people eat simply be related to the insulin that people are producing? So we might see different insulin responses in different phenotypes, and we may even see brisk insulin responses representing possible diabetes down the line as a marker for coronary artery disease. Well, my interest in this led me to get my own glucose tolerance test performed, and I did that with a friend of mine. Now, I went through school as a distance runner, slim, could eat pretty well whatever I liked, no family history of coronary artery disease. And my good friend was a power athlete, rugby player, sprinter, and premature coronary artery disease in his family. We both went and did glucose tolerance tests, and these are the results. You can see my fasting glucose at 0 and 2 hours was 3.8 and 3.9. This is after a glucose challenge, and you can see my fasting insulin was low. My 2-hour insulin, 15. Let's compare that with my good friend who has a different physiology, a power background, and a coronary artery disease family history. Well, his resting sugar, his fasting sugar was higher than mine. Fasting insulin higher than my 2-hour insulin. And if you look at his 2-hour insulin level, you can see that he produced an enormous amount of insulin to keep his sugar within a non-diabetic range. If we're thinking about area under the curve, this is an enormous exposure to insulin. We're talking multiples of 10 to 100 times difference in exposure, and this is genetically driven. I think this underpins the non-diabetics who we see who look diabetic, who have central adiposity, metabolic syndrome, increased waist to hip ratio. They supposedly have normal sugars. They have that lipid profile with small, dense particles, raised triglycerides, low HDL, and often that family history. So this is the sort of glucose tolerance test that those individuals who I've seen through my own practice have, and I got into the habit of doing 1 hour simultaneous glucose and insulin measurements because I just didn't trust the 0 and 2-hour measurements. And this is a patient called Dave. His glucose tolerance test was reported as normal. And if you look at the 2-hour insulin, 2.5 is not normal. It's low, particularly if you compare that to his fasting insulin. It was not normal at all because it was missed. Because when this test was first done, I got him to repeat it with a 1-hour set of bloods. There was no appreciation for the insulin impact on the result. And what this shows is a hyper-responsive hypoglycemia from a brisk insulin response. This is not normal. As we recognize insulin responses different between individuals, this can give us the chance to think about how we might advise different people with different insulin sensitivity to eat differently. So the public health guidelines, which are broadly applied, don't make sense. We can apply broad guidelines for the people who can eat what they want, but we need to be smarter about the people who may not, because of genetics and insulin sensitivity, may not respond to those sort of eating guidelines. This is Sam, again, one of my patients who was good enough to go through a glucose tolerance test with 0, 1, and 2-hour insulin and glucose with 3 different challenges: a glucose tolerance test, if you like, a healthy, grainy wholemeal toast apple alternative instead of the glucose load, and a low carbohydrate challenge, 2 boiled eggs and 2 slices of ham. If you look at the levels of insulin here, you'll see that with the low carbohydrate exposure or the low carbohydrate challenge, there was almost no shift in the insulin levels at all. And this is, I think, a really important understanding, particularly if we start to put in into our reckoning that exposure to insulin or total exposure to insulin is problematic. With the low carb option, his exposure to insulin is markedly reduced. So by starting to understand this, could we evaluate coronary artery disease differently? Could we advise public health people differently? Could we intervene with different strategies, and hopefully could we change outcomes? Well, one would hope so. This is a patient called Bruce. To give you an idea of what his insulin was like, you can see he had borderline insulin. He didn't go over 11 for his 2-hour glucose tolerance test. But look how high his insulins were, and look how they crept up, we challenged him, or I challenged him with a slightly more sensible, if you like, broader approach, eating guideline with wholemeal grainy toast and an apple instead of the glucose challenge. And you can see this gave rise to much better insulin control. And then I ran him through the process, just as I did with Sam, using a low carbohydrate challenge instead. And you can see this is really doesn't shift the needle at all on his insulin response or shift his sugars. One would have to start to think that if insulin is problematic for that cardiometabolic process, this is reducing that exposure. I just, by way of being a bit cheeky, also gave him a Heart Foundation tick of approval meal, which showed good glucose control, but actually drove his insulin response. These are all those numbers in summary. You can see a low carbohydrate challenge really did give a low insulin response. But this is the bit that's really important. The top figures here show a glucose tolerance test after 6 weeks of reduced carbohydrate eating. And you can see, compared to the initial glucose tolerance test, a significant reduction in insulin levels and glucose levels, showing us that we were able to improve this gentleman's insulin sensitivity. So Bruce, really a brisk response to a carbohydrate challenge. His numbers showed us that low GI is better than high GI, but not as good as low carb. Showed us that the Heart Foundation tick of approval meal was respecting sugar, but wasn't really respecting insulin. And really, really importantly, it showed us that 6 weeks of a reduced carbohydrate eating regime could start to restore insulin sensitivity. So what we do observe is that current public health measures are not working that well. So with that, the low food pyramid, which is really starting to move out of date, hasn't worked. And it really looks about fat being the problem and ignores sugar as a potential issue, and certainly ignores insulin as a possible problem. And this is really important because if we're giving sugar or carbohydrate to type 2 diabetics, we can't possibly expect them to reverse that diabetes. What I'd like to really throw out there is that instead of thinking about sugar and being glucose-centric and making generalizations with public health guidelines and eating guidelines, that we start to drill down and respect insulin as a more individual guide to what we do for people. We currently have chubby kids, metabolic parents, and diabetic grandparents. And unfortunately, to a large degree, we are not acting until we get to diabetic grandparents. And part of the reason, I believe, is because we don't have a diagnostic handle to apply. And because we don't have a diagnostic handle, we don't have a set of responses. So we don't call kids fat kids or chubby kids because of the stigma and because we don't really know what to do with them. Similarly, we observe metabolic parents, and although we look to GLP-1As and exercise and so-called lifestyle modification, we're not really winning. But we've got an armamentarian. Once people's sugar gets too high, I'd put to you, that's too late. I think we need to move to insulin underpinning the disease process and move away from being glucose-centric. I think this is really important, particularly since the definition of diabetes itself really just relates to sugary excess in the urine. And that so misses the fundamental process of what we see clinically. If we were to adjust the nomenclature, perhaps, like my friend, we could look at giving a term to his metabolic status, his physiological process, and call him a brisk insulin responder or a carbohydrate sensitive individual. His parents, or his dad in particular, would have been in his middle age, someone with high circulating insulin and a brisk insulin response. He would have been insulin in excess syndrome. And when that process continued to the point where sugars were elevated, he would have been high insulin, glucose elevated. Now we know that type 2 diabetics after time can burn out when they're not producing enough insulin, and at that stage they become low insulin, glucose elevated. Thinking about the nomenclature in this way really allows us to conceptualize it in a different way and target slightly differently, not thinking about sugar and managing sugar, but thinking about managing insulin and insulin response. This is what it looks like. As we think of people with low insulin levels, we're thinking primary, absent low insulin, type 1 diabetics. We're thinking late, type 2 diabetics, or secondary low insulin. So these would be low insulin with glucose elevated. Then, of course, there's a normal spectrum. There's people who are very insulin sensitive. They don't put weight on easily. They don't crank their insulin up high. Then we get people who do crank their insulin up, respond briskly, if you like. These people are maybe prone to put on weight, particularly if they're not exercising and enjoying too many carbohydrate foods. Then we've got the high end of the spectrum where we've got carbohydrate sensitive individuals, where we've got metabolic syndrome, insulin in excess, and we've got type 2 diabetics where we're seeing high insulin and glucose elevated. This allows us to put a handle earlier on in that spectrum of disease process where chubby or fat kids become carbohydrate sensitive individuals, and suddenly we've got mechanisms to deal with that diagnosis. We're not just calling them fat kids, we're calling them patients that have a particular metabolic process that left unattended will cause them troubles. Insulin in excess makes sense. We start to address that insulin in excess, and I don't even need to mention the grandparents. So sugar and insulin clearly have different pathological effects, and we see that clinically, macro versus microvascular disease. We know that the current management of diabetes continues to focus and be glucose-centric in spite of type 1 and type 2 diabetes being very different conditions. There's a real opportunity, I believe, to come way back to the early part of the disease journey for these individuals and recognize that we respond differently. This could allow different public health advice by isolating and renaming and redefining these individuals. I really believe there's an opportunity for a change in paradigm, which moves from glucose to insulin being problematic as an opportunity for changing the way we approach. And I'd like to end it there. Thanks so much.